for those who might not be familiar with the Leapfrog Group, in the year 2000, they began to analyze healthcare data on quality and safety so people could make better care decisions for themselves and their family. Their focus on transparency has helped the healthcare system rebuild trust by promoting high value care, and has helped trigger giant steps forward in the safety, quality, and affordability in healthcare. In 2020, the ABIM Foundation awarded a grant to Leapfrog to explore the feasibility of expanding its lives and dollars lost calculator, which estimates the number of lives lost and the amount of dollars wasted due to racial, ethnic, and language-based disparities in harm. We're joined by Leah Binder, and I just want to say something. When I was in 2000, I heard the Leapfrog Group. I said, what does that mean? And I was told that meant giant leaps forward, not incremental change, but dramatic change to really improve safety. And I think our guest speaker, President and CEO, Leah Binder, represents that notion of real, powerful, progressive leadership, bold, courageous leadership that she's always found. Under her leadership, the Leapfrog launched the Leapfrog Hospital Safety Guide, which assigns letter grades assessing the safety of general hospitals across the country. She's been named in the Becker's list of the 50 most powerful people in healthcare and consistently cited by Modern Healthcare among the 100 most influential people and top 25 women in healthcare. Now, interestingly enough, Richard Barron, who is board certified in internal medicine, geriatric medicine, and the president and CEO of the American Board of Internal Medicine and the ABIM Foundation. It's interesting that we have Leah, who represents kind of a system quality, and Richard, who represents an individual competency frame, are talking to each other today about their views about trust and safety and how we assure that. So now I'm going to turn this over to Richard, and look forward to your comments in chat and the Q&A to follow. So Richard.
Thank you so much, Daniel. Thanks, Leah, for making the time to do this. Thanks to all of you joining us this afternoon to be part of this conversation, and it will be a conversation. As Daniel described, critical to Leapfrog Group's work is the way in which you are crossing boundaries and involving different stakeholders in a conversation. And when you work on behalf of patients to advocate to improve safety and to try to increase patients' trust in clinicians, you need to work with the healthcare delivery system side too. How did you get trust from the hospitals and health systems with whom you work in the process of trying to do the work you do?
Well, first of all, let me say to Daniel and to you, Rich, thank you for having me. And I am really honored to be part of this conversation today, and also to have been part of your work around building trust. I think this is a really important campaign. I do think that trust is a really critical issue in healthcare, and we do all have to work together, and we have to have candid conversations like this one. So I really appreciate your involving me in this and your leadership in this really important conversation in the general sense, not just with me, but the general conversation that you're engaged in with the whole healthcare system, really. So, I think what we've done to build trust with health systems, the number one most important, I think, principle that we apply to everything we do at Leapfrog is transparency. We are absolutely candid and open and transparent about everything we do. And it sounds like, well, that sounds nice, but everybody does that, or everybody says they do that, but we really do it. And it actually is unusual in some of the work that we do to be as transparent as we are. So an example would be, when we launched the hospital safety grade, that A, B, C, D, or F, we give every general hospital. We use 30 different measures now of safety to incorporate that into our overall grade. And there's a method to it. And the grades, every measure is not worth exactly the same as every other measure. There is a scoring to which measures count more, et cetera. There's a method to it. And most of the time when you see ratings of anything, whether it's in healthcare or not, they won't tell you exactly how it's done. But we tell the hospitals and the health systems how we do it. We not only do we print the methodology, but we give every single hospital that's graded, we give them a calculator so they can figure it out for themselves and just see, do we get it right? We give it to them well in advance of when we publish the grade so they can check the data themselves. We give them links so they can check the data themselves and make sure that we got it right, but also really look at what if we'd done better on this measure, how would we look in the grade? We want them to have as much information as possible and to really understand it. I think that's the best we could ever do in building trust. So every hospital, every health system may not agree with us in how we approach issues around safety and quality. And they may not even, sometimes they don't even like us much. Some don't, I have to admit that, but that's okay. As trust doesn't necessarily require that we're all best friends. It does require that we have integrity and candor. And that is the principle that Leapfrog lives by. And for integrity and candor to be communicated, it requires absolute transparency. So that's really our fundamental principle.
So transparency is clearly so important. And a lot of what you're doing is relying on a logic model of the more information that's out there, the better people will be informed, and the better world, better choices people will be able to make. And we'll go a little further down that road in a minute, but another thing that sometimes builds trust is some forms of co-creation. So you're applying various kinds of quality and safety measures to health systems, hospitals. How were they involved? We hear this a lot in working with patient groups that don't come to us when you've got it all figured out and it's all baked. Bring us in when the work is happening. How did you manage that phase of your work?
We have pretty strong relationships with hospitals and health systems and leaders in hospitals and clinicians, as well as researchers, to try and develop the right measures. We don't create measures, but to develop and identify the right questions for our survey that are based on evidence-based measures. So we are always looking to the healthcare community for the best insights on what those are. And also when we're setting standards on our survey, so I should say this, we have the Leapfrog Hospital Survey and the Leapfrog ASC Survey, which are surveys that we ask hospitals and now ASCs to complete and return to us. The purpose of the survey is to ask hospitals whether they meet our standards for quality and safety and the extent to which they do or don't meet those standards. So that's really what it is. It's not about, are you the greatest thing since sliced bread, or are you sort of medium? It's about, did you meet our standard or did you come close, and how close did you come? So we use cell phone bars to report that. 4 bars, you fully met our standard, and 3, you didn't, but you're close, et cetera. So, and the reason I mention that is that it's actually very tricky to determine what is the standard. When we, for instance, started reporting on early elective deliveries back in 2010, nobody was reporting on that. That had, literally, we had no data to go on. How are hospitals doing? What would be meeting our standard? What percentage would meet our standard for early elective deliveries? And since nobody knew what the percentage actually was to begin with, we had no way of setting that. We really needed to go out to the hospital community and to other researchers and try to understand it. So we ended up, after many conversations and discussions with systems, we ended up setting one standard at, I think our first standard was 10%. And then we ultimately found out that the average was 17%, but it came down very quickly after we started publicly reporting by hospital, which was wonderful to see. And now it's The average is about 2%.
Wow.
And our standard lowered the next year to 5%, because what we saw was, even though the average was 17%, there were a good number of hospitals that were well below 10. So we felt like, well, that's teaching us from this data that hospitals know how to do this. And we need hospitals to learn from each other so that they can meet those highest standards. So all this to say that not only are we reaching out to the healthcare community for insight into the clinical and measurement science behind measures that we're looking at, but also for insights into how we score so that we are both realistic and we are have high standards. I mean, Leapfrog is not about base standards. We're not about, do you comply? Leapfrog is about, are you reaching high standards that all of us want for the care of our loved ones? So are you reaching that standard? And so, but we really need to work with hospitals to understand how to gauge that, how to score that, and how to give hospitals not an impossible standard where they just feel like, oh, forget it. What's the point of being involved in this whole thing anyway then? But a standard where they feel like it's a reach.
That's such a
standard.
powerful story of data driving improvement and of picking something and not really knowing what you're going to find, and then discovering, hey, there's variation here, but there are some people who really are able to achieve better than we imagined they could, and if they can, maybe others can as well. That's a really powerful story about using data to try and drive improvement, measures to drive improvement. When you talked earlier about transparency and it being central to what you do and part of how you build trust with the hospitals, of being transparent with them about what the methodology is, about they can score themselves, they don't need to be as surprised on what their scores are going to turn out to be. Can you give your favorite story about transparency building trust, transparency driving change by itself?
Yeah, this has become my favorite story. It's a fairly recent story. I'm really not going to name the hospital. I will name them later on, maybe in a couple of years. You'll see why in a sec. This is a hospital that was is a safety net hospital. They have many challenges. They are in a neighborhood that suffers from pretty much every challenge of the social determinants of health you can imagine. I mean, this is a very, very difficult situation for the patients at this hospital. And so they had not actually had enough cases to get a reliable score in the past, but they did. All of a sudden, we were able to grade them. And the grade was an F. And so we don't give a lot of Fs, but we do give them. And we give Ds too, by the way. We give every grade. But we don't give a lot of Fs, and but it's based entirely on the data. And again, transparency is really important to us. So you don't think it's just because we had it in for this hospital. You can look at their data yourself. Anyone can go on our website and look at any hospital's data, and you can see for yourself why we gave them an F. Maybe you disagree, but the data's there, you make up your mind. But this hospital really did poorly on a whole range of measures, and it was a frightening performance, really. I mean, it had very poor safety outcomes. So we gave them an F. So the hospital was not happy with us, and they felt that we were punishing them for being a safety net hospital and don't we understand the challenges. And we said, and I stand by this, that although it is obviously much more difficult to run a safety net hospital than other kinds of hospitals, nonetheless, safety is not an expensive thing to implement. It's expensive in terms of the time and effort of your leadership, and every staff person who works there has to be focused on it. But it is not necessarily expensive the way other kinds of quality measures might be. It's expensive to be excellent at radiology. You're going to have the latest equipment. But it's not expensive to be good at hand hygiene. That means everybody has to wash their hands all the time. You have to monitor it carefully, make sure it's happening. And then you have to act on it if it's not. And those are actions that take place. Those are commitments and actions and passions within the hospital itself that lead to those results. So we strongly believe that every hospital in this country can achieve excellent safety results, regardless of whether they hospital with lots of resources or one with very few resources. And we see that. We see lots of hospitals that are safety net hospitals or have very few resources that get A's from us. And then we see lots of hospitals that have plenty of resources that get lower grades. So anyways, this hospital got an F. They were upset. But what we heard is that in addition to being upset, they were mad at the state because they hadn't gotten their Medicaid funding, and the state came forward with the Medicaid funding right away because their F got a lot of attention. And they said, look at this. This is not right. We need our money. And then other hospital systems came in to help them. And the CEO, who couldn't get any traction on a variety of projects that involved getting their quality together, and sometimes those are hard projects that require some difficult conversations, those had not been, he didn't have the chits he needed to make those calls. The F gave him those chits. All of a sudden it became an urgent thing for this board. We got to fix this. We can't be embarrassed like this. And so so all of that came together. It's like an external force that gave the leadership of that hospital what they needed, both financially and in terms of just will to get done what they needed to get done. And they waged a huge, I know they worked incredibly hard over the past year to try to get this grade fixed. And so they got a C in the last round, the spring round of the hospital safety. We update every 6 months. And we updated a couple weeks ago for the spring round, and they got a C, and they're all excited about their C now. C is not a great grade, but for them, it's fantastic. And they did so much better. And for me, that is what it is about. And I know they're going to get an A. So that's why I said in a couple of years, I'll tell you which one it is that then I can tout them too, because I really want to tout them. I can't tout a C entirely, but I can tell you that they should be proud of it, and they should go out and get an A, and they will, because they've got the wind behind their back now, and that's what we aim to be. We don't know how to run a hospital. I don't know every technique it's going to take to become safer. I wish I did, but I don't know all of them. But I do know how to be the wind behind the sails of hospitals that really want to head in the right direction. We will push you there, and hopefully we'll all get there. So anyway, this hospital really inspired me.
Well, an inspiring story, and that we all need to know that change is possible, that not having resources or feeling like you don't have resources doesn't let you off the hook of needing to run a safe culture and needing to be doing what you can to get better with what you have. And if you were able to focus attention through your process management attention, leadership attention, that's a great story. So you've talked some about the work with the hospitals and motivating them for change. You do a lot of work directly with patients and families. I'd be really interested to hear your reflections on what's the thing that surprised you most in the work you do with patients and families in the safety space.
Well, the first aha I had was from Marty Hatley, who is on our board, and he's a major patient safety advocate. And he's educated me on a lot of things, but one thing that he really educated me about was this notion that patients are experts. He said, you can get an expert physician who knows a few things about your condition very well, and they're experts in that. Or a nurse who knows a lot about your ongoing care, and in a very sophisticated way. Nurses are very well educated. They know those things, and that's helpful. You can get experts in a whole variety of areas who work in a hospital, let's say. But the patient is the expert on their life, their experience, and everything that's happening in that hospital. So if you want to know, does the trash get taken out as it should? Is the room set up in a way that it should be? Is it clean? Are the nurses as responsive as they should be? How's things? Are they frustrated? Are they seeming to have bad days? Are they burning out? How are the physicians? Do they have a 360-degree knowledge of everything going on in a hospital? So in fact, they would be great insights for any CEO of what is really happening in every aspect of your hospital. Is it all coming together for the benefit of the patient, which really should be the goal? Isn't always, but should be the goal. So in thinking about patients as experts, it actually changes the way we begin to think about everything we were doing at healthcare. I mean, in Leapfrog, we're thinking, well, if the expert or patients are bringing an incredibly unique but a very critical expertise, how do we think of them as experts? And one of the things we did was we formed an expert panel. Now we have a lot of expert panels that are and we have amazing experts who volunteer their time for Leapfrog on a whole variety of clinical and research topics. Now we have a patient and family expert panel. And that's been an exceptional panel. And it really helped us to think. So it's not an advisory board or something else. It's an expert panel. We need them to weigh in on everything we're doing from the perspective of patients and families. How does this come together for the patient? And it's been really effective to bring ideas and updates that we are considering for our survey and everything that we're doing with both of our surveys, as well as our grade, and bring it to them and really think it through from the expertise of the expert panel. And one of the things that they did that's new on the surveys this year is work on a standard for patient consent, which is a really important issue. And I had not personally thought of all of the aspects of consent that can be frankly screwed up, and I probably are all the time. But giving patients enough time, writing it in language that are developing consent procedures and forms and that are understandable, and just a whole variety of standards that really help to make it something that is a meaningful consent when given. So a really important piece, I think, addition to our survey that came out directly out of that expert panel.
Well, that's great, and goes to what we were talking about before of co-creation, that if you're going to be creating standards and you're going to be working in this space to serve patients, it's pretty important to figure out a way to be able to create dialogue with them and have them be advisors for you and experts for you. I love that term, the patients as experts. I guess when I think about you working in the patient safety space, that's obviously a fraught space for patients and families, because there are stories of patient safety improvements, as you were describing earlier, but there are also very painful stories of patient safety disasters and people being permanently injured and even killed by safety errors. Talk about what you've learned about working with patients and families when safety doesn't go well.
Well, I wish I had learned enough to say what we can do, and frankly, we don't always have we don't have the answers. I think what I've learned is there aren't enough opportunities for a constructive outcome from a bad safety situation. So we have heard stories, we tell the stories, and we collect the stories, but we don't necessarily feel like we always have the ability to solve the systemic problem that caused that error in the first place. So I unfortunately feel like that's a major omission, not just for us, but really for the healthcare system. There's a malpractice suit, but for a whole range of reasons, that's horrendous for everyone. But I mean, that's a major source of some kind of outlet for when patients have been harmed. But there's other forms that aren't, I guess you can report to the Joint Commission, you can certainly report to CMS, but those things don't always lead to the kind of results that people would really like to have. So, I mean, I think of that a lot with this new case from Vanderbilt with Vedanta Bot, because that was a situation where there just were no winners, but the story was really publicly reported because of a whistleblower. So it just was, we don't have a really good system. We need like a national patient safety board, which is something we've advocated with a whole coalition of folks that would look at the National Transportation Safety Board in the airline industry and have something similar for patient safety, which would allow for that kind of reporting And then for a root cause analysis that involves patient and families afterward, that would help us to take terrible things that happen in hospitals and learn from them so that we can avoid them in the future. We just don't learn from mistakes that often in healthcare, not enough.
But I've heard you talk about the role of transparency and managing errors and in dealing with safety culture, transparency with patients and families. And of course, one of the challenges in the non-devote case, as you mentioned, is that at important phases of what happened, there was not transparency. What's been your experience with patients and families and safety in terms of how transparency helps people get through difficult challenges?
Well, what I've seen and heard from our expert panel and from many of the patients and families who have been active with Leapfrog is that, and I'm always struck by this because it's so poignant. Most patients and families who endure even the worst possible problems really just want one thing. They want to do something so it never happens to someone else. And I hear this over and over, and I'm always struck by it. You can hear stories of just unimaginable tragedy that people go through that's preventable or just happened for no reason in a health system. And they will say, I just want to be part of the solution. I just don't want this to happen to someone else. I'll do whatever it takes. And I think that health systems that start to realize that can get past their orientation toward immediate risk management and be quiet and no one say anything and get the lawyers. The minute they start doing that, they've done the opposite of what the patient really wants out of this terrible tragedy. What the patient or family really wants is them to do the absolute opposite of that. They want them to be candid, to figure out what really happened here and how can we never have it happen again. And for the patient to be and the family to be part of that in a candid way. And so they feel like they're part of the solution. And there's studies that have been done that when you apologize to a patient and you involve them like that and you're candid, they are less likely to sue. So there is really a reason, even from a risk management point of view for a health system, just to think differently about how they approach patients. But even that's just one reason. That's maybe a risk management approach, but it's also just humanity. It's just being humane. And we have to start to think, that's enough of a reason. Even if there isn't a good quote business reason, it's humane. It's just the right thing to do with patients. And we have a standard that for Leapfrog that many hundreds of employers have embraced. And most health plans have embraced as well. It's our never events policy, which is that we expect if there's a never event, which is defined by stakeholders at the National Quality Forum, events that they're like sentinel events that should never happen. They are events that are therefore always avoidable. So removal of the wrong limb in surgery is a never event. That should just never happen. There should be enough checks and balances in place within a system that it doesn't happen. Of course, things like that unfortunately do happen. And when they happen, our policy is that the health system doesn't charge for the event, that they apologize to the patient, that they do a root cause analysis, they report it to the appropriate officials like the Joint Commission, and that they engage families and patients in the root cause analysis, and that they have a care for the caregivers policy in place. It's public, it's well known. And then that they also make this policy public. So the caregivers policy is very important to us because we think it's really important to have a culture of safety, and that means a just culture. People who are caregivers in health systems are there because they care about people. And if they make a mistake that leads to someone's death or someone's terrible suffering, that's awful for them too. And there needs to be a policy to help them through it and to make clear to the rest of everyone else that we're going to work on this together and get through these experiences so that we're better at the end of it. So I just think that sends the right message in a culture, and we know it does. That's why we have it in our policy. So anyway, that's our policy. It's based on a number of things, but it's mostly based on Candor, which is a framework that was developed by ARC and piloted at MedStar and University of Michigan. And both of them we've been very impressed with their work in this area, and we would strongly encourage anyone who is interested to reach out to them, or just go online at ARC. You can get the whole Candor toolkit.
Well, it's so, I mean, medical errors are such a trust destroying moment. Obviously, when patients put themselves in the healthcare system and under the care of clinicians, nurses, doctors, they're counting on people to do the right thing. And when people don't, it's trust destroying. And I think what you're describing is a model that can at least have some shot at restoring trust through
Absolutely.
transparency, honesty, integrity, and admitting fault is clearly part of that, and acknowledging what happened is clearly part of that. And it's great to have a standard in that space.
That's right. That's exactly right. Trust is, it restores, it builds trust both within the organization, among the workforce, and certainly with patients. So I also think that if there isn't disclosure and there isn't this sense that we have to be candid and open with each other about these mistakes when they happen, I think it also creates burnout and just real problems with the workforce. Because people, again, they come to work every day because they care about their patients, they care about people. And to be in a situation where you cover up things that harm people, or you're just feeling like you're not doing the right thing for people, has got to be a terrible sense of cognitive dissonance, and just this sense that I'm not doing my life's purpose. That's the kind of thing that leads to burnout and people switching careers pretty fast if you don't feel like you can live out your life's purpose, because your work really matters to people. It should. So I think that there's a lot of good reasons for us to all start thinking more clearly about how we approach these problems.
Well, it's so important to hear the ways in which Leapfrog standards drive people in the direction of better behavior that not only benefits patients, but benefits caregivers. That's really valuable to hear. So shifting gears a little bit, we've just been and continue to be in the midst of a pandemic, and which has highlighted longstanding issues of trust and inequities in the healthcare system. It's added a lot of stress on hospitals. How did Leapfrog approach dealing with its work in the context of the pandemic, and what do you think the right response is for how institutions that are trying to evaluate and assess and encourage better healthcare performance? What's the best way? How did you think about that?
Well, I can say how we thought about it and what we've tried. I don't know if it's the best, but I will say what we've done over the past couple of years, but particularly the first year of the pandemic, is we did adjust some of our requirements on our surveys so that it was a little easier for hospitals and ASCs to complete them. We changed some of the deadlines. We tried to make it a little bit easier. We did not require a culture of safety survey to be done until 3 years had passed, as opposed to 2 years, which is the standard for us now. So we had a few adjustments that way, and we tried to make it easier. But I think the second year we phased many of those out, and then by now they're gone. We're not doing anything. And the reason we're trying to get right back on is right back full speed ahead to excellence, is we are deeply concerned that there's been a major erosion in patient safety over the course of the pandemic. I mean, to your point, hospitals have been under enormous stress, and we've been dependent on them in ways that most people would find difficult to shoulder. I mean, we've really leaned on hospitals, and so it's been difficult. That said, we still need them to be safe. We can't give them a break from that. And unfortunately, they haven't been, not all of them anyway. According to an article by the New England Journal of Medicine, which was co-authored by 2 leaders from CMS and 2 leaders from CDC, there has been a major deterioration in safety on hospital-acquired conditions as well as hospital-acquired infections, and that we actually reversed all of the progress we made on some of the hospital-acquired infections. So we had made some progress in the past 5-10 years, and it's gone as of these last 2 years. Very disturbing data. They made the point that we need resilience, that health systems need to, and I like that word, they need to be more resilient. When there's a public health emergency, we still need to be able to keep our patients safe. Not easy, I get it. It's hard to, it's easier to say it than it is to do it. But we're entrusting our lives in these hospitals, and they have to find a way to make sure people are safe. So we don't want there to be any more, we want to keep the standards high. We're going to keep our standards high. And we need CMS to do the same thing. We need everybody, Joint Commission, everybody's got to keep the standards high. Hospitals don't, if they don't meet them, then they have at least the challenge in front of them and they know where they have to go. But and hospitals are going to have to recommit around safety because we've had a major setback. And people are dying as a result. This is not a small thing.
No, not a small thing at all. And in that sense, I'd hope that the framework created by Leapfrog becomes a resource for hospitals to find their way back to a safer culture. That if they're seeing deteriorations in performance at CMS reporting, my guess is your surveys are going to document that too, and maybe pinpoint places where people have opportunities to improve. I certainly hope that it works out that way, and that you become part of the pathway back. But of course, another thing about the pandemic was that it showed, it put a spotlight on health equity issues. And I know our foundation has been working together with you to try to address health equities through your Lives and Dollars Lost calculator. Can you tell us more about that tool, why it was created, and how you think it's actually out there? And after this question, I think we're going to go to Q&A. I know Tara Montgomery already put a question in there, and so I know we won't lack for questions. If people have questions, feel free to put them in the chat, and that's probably safer than trying to hand raise. But Leah, can you talk about the Lives and Dollars Lost calculator?
Sure. So I should say that the Lives and Dollars Lost calculator has been available for, it's a different thing. We've had it for many years. What ABIM Foundation supported us to do was to bring together experts, many of them recommended by ABIM Foundation, which thank you, they were fantastic people that came together to help us develop, to adapt it so that we can understand better disparities in individual hospitals between the patient safety outcomes for Black, white, and other patients by ethnicity, potentially other factors, but we're looking at those two right now. But so what the Lives and Dollars calculator does right now is it estimates lives and dollars lost to patient safety problems. It allows, employers can enter, or anyone can enter, the number of people who are going to which hospitals, and we can estimate for them what, based on the data about different patient safety events that we know happen at these different hospitals, what will be the mortality rate, and what are the estimated dollars that are going to be wasted as a result of it. So again, that's all developed by a team at Johns Hopkins, and it is based on very good evidence on how these hospitals are doing. But what we really want to do is adapt it for these health equity issues, because I think what ABIM Foundation, Daniel, and you, Rich, had told us is that it's really important for people to understand when we talk about health equity, we're not just saying, in general, we know that these outcomes for people are different depending on your race or your ethnicity. We're not actually, that's like a general statement, and we can all say, oh yes, we recognize that, and we all sign on to our statements, and that's the end of it, right? We say, oh yeah, this big problem. It's very different when I say it's your problem in your hospital, in your ASC, in your place of business. you have this problem.
Hmm.
Your patients are being treated differently when they come to your facility, and they're getting worse outcomes depending on their race or ethnicity or other factor. And you need to see it in order to act on it. And so part of what we're working on, and it's not easy to do this because unfortunately the data is not all that great around patients and race, ethnicity, language. That data is still at what I would call infancy in terms of its connection to health outcomes. So we're still working on it, but that is the next phase with this calculator, is to update it to be able to do that. And we're working on that phase now. So we don't have that data. We don't have the new calculator yet, but we will. And that is something that we are hard at work at. But
Okay.
the idea is really just to tell you it's you, not just generally in the United States, but you.
It's so powerful, your observation that people can say, oh, yes, we know there are health equity issues, but they're not mine. Your ability to shine a light on that and illuminate what kinds of changes people might make to move the needle in that area, I think it could be really important. And we don't live in Lake Wobegon. Everyone is not above average, and people being able to identify when they're contributing to an overall national outcome is clearly an important space to be in. And thanks for being in it. Thanks for helping. Well, we do want to be sure that people who've joined us get a chance to ask some questions. And Daniel, do you want to moderate and tee up for Leah to respond to?
Our good friend and colleague, Tara Montgomery, has used the words of an author that we're very familiar with, Rachel Botsman, and maybe both Leah and Richard can comment on this. So Tara, why don't you ask your question?
Hi, Tara.
Yes, hi Leah. And this is a wonderful conversation. I'm an admirer and ally of your work on transparency. I accidentally posted a really long quote. I didn't mean to do that to distract everyone. But the essence is, so Rachel Botsman, who's a scholar on trust, said to me face to face that I was mistaken to care so much about transparency in healthcare. And she wouldn't mind me saying this to you. She said, trust is what happens without transparency, in spite of transparency. And in a way, she really shut me down. And I didn't know what to say back. And I wondered what you would say back.
I've never heard that statement made by anyone, but okay, here's what I would say. I would refer back to data. So we did some focus groups, and I have talked to other colleagues who've done similar focus groups among ratings, organizations that do ratings of healthcare and other things. And so this focus group was really studying individuals and how they responded if they heard that a hospital had a bunch of never events. And we named the never events. And we said, how would you respond if we told you that this hospital had a high rate of objects left in after surgery? Really specific things, and in layperson's language. And the answer, and we did one-on-one and focus groups. So we did a lot of one-on-one stuff. And we did it, and we had this one-on-one, and I just remember these people would say, well, that can happen, I guess. Ugh. I guess I'd just talk to my doctor and, I'd be concerned about it, but it can happen. I mean, they were very sort of not like it was nothing, but matter of fact about it. Then we said, what if we told you that that hospital declined to report on how many objects were left in after surgery, or declined to report on all their healthcare outcomes? And in literally every case, 100% of those that we interviewed in this study, 100% of the time, they responded with extreme emotion. What are they trying to hide? Why wouldn't they tell me? I go to that hospital, and then they would start to tell their stories about, and my wife had this problem, and then it just triggered.
Mm-hmm.
credible emotion about how bad hospitals can be. Not objects left in after surgery. That did not trigger that emotion, even though to me that would, because I thought that would. Honestly, when we did the story, I assumed, of course, that's, most people don't even realize all the things that can happen, and they don't. But I think they recognize that if I hear about it, I'll talk to my doctor and he'll be honest with me, or she'll be honest with me. That's what they want and expect. But the idea that they would hide it was triggering. So all I can say is just, maybe it's a values thing, but I can also tell you that we have lots of research that shows people do not accept when you're trying to hide something. Do not hide.
That's poignant.
Richard, do you have a comment on that?
Yeah, I wonder, Tara, I mean, I am a huge fan of Rachel Botsman. I put myself as a Rachel Botsman groupie. I learned a ton from her book. But I wonder if she isn't a little bit here, if it isn't a chicken egg question, that if you're already in a trusting environment, transparency, if you now say I need to be transparent, then people say, well, why do you have to be transparent? But I think most circumstances we're now in this country, there's a lot of skepticism. There's not reliably trust. And I find myself thinking about one of the things that, for example, some newspapers have started to do. I think the first place I saw it was the Sacramento Bee, where when they're reporting a story, there's an addendum to the story. Here's how many people we spoke to do this story. Here's the various people we consulted to do this story. And what they're trying to be transparent about their methods. And I think they're in effect approaching a situation where they're saying, we know a lot of you aren't going to believe what we're writing, so we're going to try to be transparent to help move you across. So I wonder if it's that if people feel like they need to be transparent, well, why do you feel like you have to be? And if you already are, I think it will. I agree with Leah. I think it helps build trust.
So
I'd love to keep talking about this with you, but there are other questions. So I'm going to mute
okay,
myself.
thank you very much, Tara. Great to see you. And our friend from Choosing Wisely, the president of College of Radiology, Bill Thortworth, comments, please comment on the value of openly assessing near misses and being transparent of changes based on those in an effort to build trust.
Oh, I think it's a
Thank you for your question, Bill.
fantastic idea. I think some health systems do that pretty well and some do it less well. But one I've seen do it well is Virginia Mason. A few years ago, I was there. I'm hopeful they still do this, but they have rewards for people who report near misses, and they have a board where they list them, and they have very open and transparent process for discussing them and really digging into them. So I think it's a great idea.
Thank you, Bill. Next question is, can you talk about why the major areas for improvement in the patient safety culture survey tend to stay the same over time? Communication, fear of retaliation when reporting errors. Are there any practices that actually help? How do I improve my scores on that survey?
That actually help to do what?
Well, the person's, we can bring on Sharon, but I think the question is like, those scores stay pretty constant. And here's Sharon, she can answer ask the question even better than me.
Yeah, I used to work in a health system, and I think I see one of my former colleagues here on the thing also. But just looking year over year, and also before I even worked within the healthcare system, worked with the Medicare Quality Improvement Organization for a couple of states where we were helping to support patient safety culture. And you just see year over year, here's the biggest areas for improvement. You know, how good do you think communication is? And how safe do you feel in terms of reporting incidents? And it just sort of, those are always the ones that seem really difficult to move.
One of the things is my wish list is that we could get a hold of those cultural safety surveys. We have a standard on our survey. Do you do them? And we have a standard. It's a pretty robust standard about what you do with the information. So it's not really enough just to do a survey and then to maybe file it away in the CEO's lockbox somewhere. You actually need to use it. Go to the floors and build change out of it. That's our standard, and it's a robust one. I would encourage anyone. You can always look and read our survey. It's like a checklist for folks on what are the best practices that are out there, and we update it every year based on what we learn from hospitals and health systems and researchers. So I would, anyway, we have that standard, but I would love to look at the actual surveys, and they are in many cases correlated with actual patient safety outcomes. So it would be really a great even proxy measure for a lot of outcomes, but I know that that's not going to happen too quickly. Having said that, though, it is all about how health systems use the data, and how it's always about using the data, really.
So the next question is from Wendy Nickel, the president and CEO of the Healthcare Improvement Foundation, which I have the pleasure of sitting on their board. Wendy, do you want to ask your question?
Sure. Hello, it's very nice to see you. Thank you for this terrific presentation and talk today. My question is about measures where there are major disparities in outcomes, and the outcomes particularly among historically marginalized communities along racial and ethnic lines. Is there a plan for Leapfrog to begin to evaluate some of those measures?
We have asked in our last survey round, we piloted a question, and we're piloting it again, which is about whether hospitals stratify their quality data by race, ethnicity, language, and other characteristics like LGBTQ. But what we found when we piloted the question was that hospitals didn't entirely understand what we were trying to get at, and they thought it was about sociodemographics, which certainly that's a key factor, but that's not what we're asking. We're really asking about race, ethnicity, and other characteristics. So anyway, so then we ask, what do you do once you find these disparities? And we haven't gotten to that point yet, but so everything on our survey has some evidence of disparities in the broader national data. And in particular with patient safety data, there's a study by the Urban Institute, which I strongly encourage everyone to take a look at. It came out back last summer, and it was on Black and white patients in hospitals, and it looked at hundreds of millions of claims through the ARC HCUP database, and found that there was disparities in the patient safety outcomes for Black versus white patients who were in the same hospital and had similar sociodemographic characteristics. So independent of factors we think have some impact, like which hospital you're at or your sociodemographic status, independent of that, Black and white patients got very different outcomes for patient safety outcomes, which are really all about, and those were HACs, healthcare acquired conditions. So those were measures of things that are caused by the treatment within a hospital. So we want to make sure that hospitals are focused on the things they can do something about. But first they have to know that there's this disparity, and then they have to address it. And we're focused on what they can do right now. So social determinants of health are extremely important. And I'm really glad that hospitals and health systems are looking so closely at that issue, but they also need to look internally and at the mirror and say, well, what can we do right now today that will, in our treatment, that will affect and alleviate these disparities? So that's what we're hopeful that we'll get to, but we're still working on it.
Thank
Thank
you.
you. Richard, any concluding remarks?
Well, first of all, just to thank you, Leah, not just for today, but for the way Leapfrog has moved healthcare in a positive safety direction, for the way that you've been a force for change, for positive change. And I think you have modeled some of the cores of what it takes to get better. You started with transparency. I'd go back to that. At the end of the day, your surveys invite institutions to look at their processes in an honest way. You give them benchmark data so they can compare. and they know what they need to do. And you share it publicly, which helps motivate change. So I've read lots of literature to suggest that those in the quality movement who believe that it's patients who are going to go shopping for quality, that there's a lot more evidence to suggest that it's providers of care who are worried about their quality scores and focus on it and pay more attention to it. Maybe the patients use it, maybe they don't, but for sure, the people who are providing the care do. And that's the node you've been working on. And I think we've got a safer, higher quality healthcare system in America because of what Leapfrog has been doing. We still have a long way to go, but on behalf of everybody, I just want to thank you for the work you do.
Thank you, Rich, and Daniel too, for your leadership. I'm very pleased to be able to have this conversation with you today, and I really do appreciate what you've done to move us forward, which has been an inspiration for us as well.